Welcome, everyone, to our Voices of Alzheimer's webinar. We're delighted that you've joined us in this important conversation about the Voices of Alzheimer's Bill of Rights for those people living with Alzheimer's disease. This document was meant to shine a light on the ways to improve the experiences of people with Alzheimer's and other illnesses, cognitive illnesses. First, for those of you who are not familiar with VoA, our organization, Voices of Alzheimer's, was launched as an organization in the fall of 2022 with the goal of empowering people living with or at risk of Alzheimer's and other cognitive illnesses, united by urgency to drive equitable and innovative treatment and care. We aim to create a society that respects the voices and choices of people living with Alzheimer's and other cognitive illnesses in managing their own health and well-being. My name is Jim Taylor, and my most important role is that of a caregiver for my wife, Jerry, who's been living with Alzheimer's for 12 years. Jerry, would you like to say hello?
Hi, I'm happy that we're continue our daily cases.
Thanks,
Thank
Jerry.
you.
So I'm president and CEO of Voices of Alzheimer's and really excited to be with you today for our discussion about the Bill of Rights. We'll have 15 or 20 minutes at the end of the webinar for our audience to ask questions, and feel free during the meeting to submit your questions for our Q&A session by opening the chat window at the bottom of your screen and entering your question. And if you have any trouble sharing your questions or any technical issues during the meeting, you can reach out to our hostess, Kim, by clicking on her name in the chat box and sending her a message. We'll be recording this session and posting it on our website, voicesofad.com. If you would like to share it or listen to parts of it again, you'll be able to do so on the website. If you aren't already a member of VOA, Voices of Alzheimer's, you can sign up on our website as well, and we would encourage you to do so and to support the efforts of our organization and some of the terrific projects that we have underway. So now to our program. You'll know that maybe you're aware that the Voices of Alzheimer's created and released an Alzheimer's Bill of Rights in December that includes 10 rights to serve as a guide for ensuring that people with Alzheimer's disease have a high-quality life and are given the respect and ethical treatment that they deserve. The rights in an abbreviated form are these 10. First, the right to always be treated with dignity and respect. Second, the right to be free from discrimination in any form. Third, the right to be diagnosed and treated promptly. Fourth, the right to have annual cognitive screening. Fifth, the right to have affordable and expeditious Medicare and other payer coverage of the full range of treatment and diagnostics. The sixth is that we have the right in the case of younger onset, so individuals younger than 65 who are diagnosed with Alzheimer's, to have access and the same treatment as people 65 and over. Seventh, we have the right to participate in clinical trials without facing unnecessary barriers. Eighth, we have the right to receive complete information about our diagnosis, treatment, and prognosis, and access to all medical information. Ninth, that we have a continuity of care. And 10th, we have the right to receive quality care in all medical settings. So those are the Bill of Rights in very abbreviated form, just to give you a context of our discussion today. And we have a bit of a change in the program. We had hoped to have Dr. Monica Parker, a psychiatrist, neurologist with us today, but she's been late in joining. And so our additional panelist, in addition to myself, is our own beloved Terry Montgomery, a founding board member and board member emeritus of VOA. So Terry, can you introduce yourself to the audience?
Sure, I'll be happy to. Yes, my name is Teresa. I prefer Terry Montgomery. I am living with Alzheimer's. At the age of 58, I had early onset Alzheimer's. I have a 38-year diverse career, pretty much in the area of customer service, human services, and human management services. In addition to that, I like advocating. I'm a strong believer in speaking up and making changes for those of us that's living with the disease and those that is yet to be diagnosed. And I have a very determined attitude to not allow it just make us say nothing, but say something. Thank you.
So Terry is the perfect panelist today because she was actually instrumental in some of the 10 rights that we have established, and we had a great deal of dialogue. We went through a pretty comprehensive process in developing this Bill of Rights. Several Alzheimer's Bill of Rights had been written previously. They were 10 and 15 years old, and because so much has changed in the last just few years in the world of Alzheimer's with disease-modifying therapies and changes in screening and with blood biomarkers soon to be with us, that we saw really new needs and identification of new rights, but also the continuation of a number of historical rights that we included in the document. So, Terry, let's just jump right in. The Bill of Rights contains an emphasis on the right to be treated with dignity and respect. Can you share some examples from your experience of how healthcare providers and caregivers can embody the principle to interact with dignity, to treat people with Alzheimer's with dignity and respect?
Well, one example, like when you're going for examination, I'll use it for myself for a mammogram, and then it's discovered that cancer is there. And then because you have what you have, what the history of mine was to hopefully, and then receiving that diagnosis for them to do a complete mastectomy for that side. And they were recommending a lobectomy to make an excuse for me that would be easier to manage and we wouldn't have to, it will heal faster and all of that. And I think that validates what your choices are. Why would you have to assume because you have Alzheimer's that it's something that is a quick and a quicker surgery than doing the right thing? So in speaking up, I was able to have what I needed and have an accurate diagnosis and not have to wait 3 months before I could be seen. So you have to speak up.
I think one of the very positive things to model, I often want to encourage physicians to, even though Jerry has declined somewhat with her Alzheimer's, that she is in the room, and when they have an appointment, always answer her questions looking at her. I see sometimes the physician, even a physician, turns to me and start answering the questions that have been asked rather than direct the responses to Jerry. And that carries over to care partners and friends and anyone who's really interacting with individuals with Alzheimer's. Oh boy, I see that Dr. Parker has joined us, and she's especially welcome. Dr. Parker, can you introduce yourself?
Yes, I'm Dr. Monica Parker. I am a family physician. I direct the Outreach, Recruitment, and Engagement Core for the Goizueta Alzheimer's Disease Research Center at Emory University.
Dr. Parker, we're delighted to have you. And I feel very, very excited and fortunate to have such experienced, knowledgeable, and lovely individuals on this, and Jerry right here beside me today. So this is really a great opportunity for us. So Dr. Parker, thanks for coming. I know you've got a really hectic day and you really always have an excuse seeing patients and really delivering such valuable experience and knowledge to your patients and the advocacy that you do. So thank you. And we were just starting on the questions, and we're talking about respect and dignity. And maybe we could just move to the next question. And are there ways that you have encountered that unintentionally healthcare or physicians or care partners don't show respect, and things that if you're just reminded of and are aware of, that you can be more respectful and not cause people with the disease to feel like they are disregarded? Dr. Parker, anything?
Sure. I think that one of the things that is important when you're interacting with patients, and I can say this as a clinician, is patients with cognitive impairment are still patients, and they do have assent. And so you are a care partner for somebody with challenges. That person still has a right to the discussion that's taking place. So I think providers, whether they're physicians, nurses, social workers, whomever the person is in front of, should address that person first, because that person is the patient. And then secondarily address their care partners. And it's not necessarily the fault of the provider. It's also the problem of the family who insists, quite frankly, don't talk to them, talk to me. And it's like, okay, I'm going to talk to you, but I really need to talk to them first. And when they are unable to communicate, then it's okay for you to offer an opinion. But I think that on the part of family members or care partners, whatever word you choose, and providers, it's important to honor and give the person to whom the care is being directed the opportunity to participate in his or her care.
Beautiful response. Thank you. Terry, as far as your family, your care partners, are there ways that they unintentionally disregard you, that they probably is the last thing they would ever want to do? Anything you think?
Thanks for asking. Basically, my family is very, very there to be for me, to support me. They realize that advocating, we have some advocates in our family, and definitely Sean is one that's as dedicated as I am. But the bottom line is that when I go to the doctor, they can come on some visits and some visits they don't. When there's something that's serious, definitely they are always there for things that are serious. But at the same time, in the beginning of the journey, the doctor would talk to me and the patient, but there are some doctors who don't, which is what Dr. Parker just said. And so they're pretty flexible in making sure they don't ignore me. They will say, my mother is able to talk for herself. Just listen to her. And so in having the family to back you up, to show that you are capable, to be able to know what's wrong with you, that they don't have to tell word for word, but let us tell it, and then they confirm all.
Great. I think one of the things that I learned early on from Jerry, my wife, is that I in my great desire to support her and help her, in fact, I was creating a situation where I would jump in and do things for her that she was perfectly capable of doing herself. Sorry, here I have to, a little background noise here in this facility. And she pointed out to me that unless she's asked me to support her in this way, or unless I've seen her fail, that I shouldn't jump in, because it is a form of disrespect. Not that I would ever intend that, but that I'm taking away from her something that she has the ability to do, and therefore not reaffirm that she's still very capable and very competent person. And when you're losing some abilities, not to have reinforcement that you are able to do the things that you still can is not a positive intention on our part. So I've had to learn that. And, you know, we old dogs have to learn new tricks, but I think it's very important for care partners not to be a helicopter care partner, like we have some helicopter parents. I think we, in all good intentions, can still make the same mistake. Another thing that occurred to me is that, you know, one of our physicians early on recommended to Jerry that she not share the disease, not share the information, the diagnosis. And this again was, I think, acknowledging that there is stigma out there, but we can't take it on unless we meet it full force. And so in due respect, I think one needs to be able to consider for themselves whether or not they want to share their diagnosis. So moving on. Yes, Dr. Parker.
That's a bit unusual. That's an unusual response for a provider to tell you not to share your diagnosis. I belong to the school of thought that says my personal health history, regardless of what it is nobody's business except mine. So I find it interesting that your doctor said not to share the diagnosis, because at the other end of things, you kind of have to help educate the public about challenges and to help people be more respectful, you know, and you educate by doing, and it's sort of like what we're talking about. So I think we perpetuate stigma when we stop talking about things in the open. I'm very transparent.
Thank you, Dr. Parker. I couldn't agree with you more. And Jerry, Terry, and I are really trying to personify that advice. So let's move on to diagnosis. Dr. Parker, now that we have in Alzheimer's disease-modifying therapies approved by the FDA that slow the progression of the disease, early and accurate diagnosis is crucial. How can we raise awareness and encourage people to get their annual cognitive screening, especially in the underserved communities?
Well, I'm a primary care physician, and so there are a couple of things that I advocate. Everybody age 65 years of age and older should be getting an annual wellness visit. Part of that annual wellness visit is a screen for memory and a screen for depression. Well, why depression? Because depression or apathy is one of those soft signs that indicate that there may be some brain dysfunction. And when we're able to screen for it, and particularly if people have subjective complaints, whether it's the patient or their family members, that's a trigger to the provider to do a more extensive evaluation. So how can you make sure that people in underrepresented communities get evaluated? There's a long answer to that. The shorter answer is doctors can't help you if they don't see you. If there's not a doctor in your community, a primary care doctor, you have to start with a primary care doctor, whether that's a geriatric provider, internal medicine, or a family physician. The patient, the patient's family have to let the providers know what's going on so that they can start screening. But everybody over the age of 65, as part of the annual wellness visit, which is a Medicare benefit, should be receiving a memory screen and a depression screen at least once a year. If there are subjective complaints of memory dysfunction or behaviors, that's something that must be communicated to the doctor. So on a larger health disparity scale, people who live in rural areas, people who live in areas in urban communities where there are few medical providers of any kind are going to have difficulty getting that kind of evaluation and diagnosis. So making sure, ensuring that there is a medical provider in a community, and then the community providers are given education and information about screening for Alzheimer's and related dementias and other chronic, what we call geriatric syndromes, things that affect people over the age of 65, additional training. Those are the things that we should be advocating for.
Thank you, Dr. Parker. Terry, how can we best reach the African-American community with information about the disease and begin to restore the trust in research, which is a tall order?
Well, basically, for me, I was not shy in letting it be known what I had, what my diagnosis is. And it was very important because within the African American community, a lot of us didn't really understand, what are you talking about? What's with that word Alzheimer's dementia? What does it mean? What do you mean you have it? So me, I wanted to having it in my family as well. My husband and my brother-in-law had it, and my best friend, they had it. So when I got it wasn't something I was happy about, but it was something that I felt was important because you're getting having that disease before reaching 65. So I was 58. And so it was something to find out more about, share that information, get in touch with the doctors, different organizations to get involved with, go to meetings, began to share that information, go to some seniors' memory care. I visited all of that to see what the journey would be with that, and get people involved that you can talk to your doctor, you can talk and let them know all of the information for screenings, and go to the different organizations that we have. And we'll be happy to get you into support groups, come and tag along with me on a call, but pass that into the community where you are there openly speaking about it. And that's how it gets started. You pass that information and like, oh, I didn't know you had it. Go get tested for it. And so you
Right.
don't have to wait till you're 65. Test yourself when you start. Tell your doctor about it.
Dr. Parker, you're exceptional. I think few GPs, PCPs, really are very comfortable talking about mental health. And we know through statistics that very few seniors receive their annual cognitive screening, even in their wellness visit. And we also are aware that most general practitioners do not feel that they are well enough trained, well enough supported to discuss memory issues. So how, when we want an annual cognitive screening, but many physicians are not able to be comfortable with that, how do we approach a physician, our general practitioner, about a screening if they may not be versed in these areas?
I think you have to start where you are. I work on a number of local and national committees that talk about physician education. And because I'm a primary care physician, I feel comfortable doing this, but I'm also comfortable because I'm in an academic environment where this is a part of what we do. I think that regardless of where you are, you need to ask the question. And if your doctor is uncomfortable, he or she may refer you elsewhere. There may not be an Alzheimer's disease or memory center in your immediate vicinity, but just about every state has a medical school or a training university. It may not be a medical center as such. It may be a psychological center where they do testing. The cognitive testing that's a part of the diagnostic evaluation is not done by medical doctors. It's done by the PhD psychologist, the neuropsychologist. So there are other ways to get it done. I know here in Georgia, for example, before we started the MemoryNet, a lot of my patients, depending upon where they lived, I sent them to a neuropsychologist that was closer to where they lived to get the cognitive testing done. But again, start the conversation, ask the provider. And most providers, if they don't feel comfortable, will make sure that you get to somebody who can address the issue and make sure that you get the kind of evaluation that you need. But as a patient, as a family member with somebody who's having issues, you have to advocate on your own behalf and start with the team that you're working with. One thing that I would not like to see people do is just show up in an emergency room anywhere and expect to get proper care and treatment. It doesn't happen like that. You know, emergency rooms are for life-threatening illnesses, but if you're frustrated and you're a caregiver with somebody who has dementia and they're having some challenges, address it with your provider. There are organizations around the country that can help get you urgent care, but please start with the provider in your community that's going to be your best access to different resources. And all doctors aren't going to have all of the answers. I'm not a cancer specialist, but my job is to screen and refer to the cancer specialist as appropriate.
And
I'm not a,
especially,
huh?
and especially getting that very first cognitive assessment, that baseline as early as possible is extremely important to be able to compare back to as we age and have normal aging cognitive challenges.
Okay, but the other part of that, if I may, is
Of
that
course.
sometimes the symptoms that you are looking at are not attributable to dementia, but may be attributable to some underlying medical condition that is going awry. It may be due to some medication problem or interaction. And that's why it's very important, or infection, like a urinary tract infection or a COVID infection. That's why it's really important to get to your primary care doctor to make sure that what you're seeing is not something treatable and maybe something else. So all dementia, it's not as easy to diagnose dementia as it is to diagnose a strep throat or even a urinary tract infection or a COVID infection. There is a process, but it is important to start with the primary care doctor to make sure that we're not missing something treatable that may be causing symptoms.
So Dr. Parker is pointing out that 25%, an estimated 25% of cognitive issues are reversible. And the sooner we get to the physician's office to get those identified, and that's exactly what GPs are supposed to be able to take care of or do take care of. So that's great advice, Dr. Parker. Moving on to treatment. No, let me come, Terry, let me go back to diagnosis a minute here. Nope, treatment. Dr. Parker, this is getting into kind of an area of challenge for individuals who've experienced discrimination or challenges in their treatment. But do you think that an early stage or mild stage individual with Alzheimer's should receive the same level of care for cancer as an individual without Alzheimer's?
I think the answer to that question is it's conditional. I think that everybody is entitled to a full diagnostic evaluation. They need to understand very fully what's facing them, and they need to clearly understand what their treatment options are. If you're saying, well, should somebody with Alzheimer's be treated for cancer if they're going to die of Alzheimer's anyway? The answer is it varies. If I have end stage dementia and if I'm bedbound and my quality of life is such that I am unable to do anything for myself and I don't really have much physical function, I don't have much cognitive function, so I'm not really fully participating in everything that's going on, the question of whether that person should undergo an extensive cancer treatment regimen is something that the family and the doctor have to decide. Okay, that's not for me to decide. Now, if you're like the people who are on this call and you've been diagnosed with cognitive impairment and you have a malignancy, I think that that malignancy needs to be treated. It's all about what stage disease you have. You know, at some point in time, medical treatment, whether it's cancer or anything else, there's a question of whether is it, if I treat whatever it is it going to harm this person? Is it going to improve life for this person? And if this person already has a quality of life that is minimal, you'd have to think twice about maybe subjecting that person to another treatment that may, with its in expected complications, you have to weigh whether that's an optimal use of medical resources for the medical system and more importantly for the quality of life. So if you're upright and you're functional and you can do things for yourself, I don't think that I think that these discussions are conditional. They vary from individual to individual, but quality of life is always the question when it comes to treating somebody for something.
Well said. And I ask that question because I know that Terry, in her experience, having been diagnosed with cancer and with Alzheimer's, has had some difficult experiences in her treatment. And Terry, maybe you can share with us, do you think that your treatment was influenced by the fact that you are African American, or was your cancer treatment, in fact, maybe reacting to the knowledge that your cancer team knew ahead of your Alzheimer's diagnosis?
Having that, and that's a good question, because for my journey, I was fortunate enough to have my family back me up. So what I mean is that some cases, it all depends on who you're seeing and where they may see your quality of life. And mine, and then have a misdiagnosis on top of it. So in my case, my family taken me to a different doctor for a second opinion. There was a misdiagnosis that was given to me where I had cancer in one breast. They actually was in both. And then having that and getting over that, seeing that I had a quality of life, that I still was with it, understood everything, they understood the processes as well. But it's something that you have to fight for. You can be in this place and they could say, no, that's it, and we're going to do this, and we're going to do reconstruction. Whereas my family was like, let's get a second opinion, make sure the diagnosis is correct, and everything was taken care of, very successful. And following, yeah, it's echoing a little bit. But the bottom line is that the family got me to additional health, to be able to have that covered, because the type of insurance, I didn't really have good insurance. You had to wait for 2 years and get the Affordable Care Act. It was limited as to what could be done. But long story short, you have to find out what resources are there, and then for them to see that you still got it. You still got some gas in you. And so if you don't have a family to fight with you along that course, you lose so much.
Good points. Thank you, Terry. Dr. Parker, Jerry and I have had several experiences recently that clearly revealed that hospital staffs, particularly emergency room staffs, are not trained in how to interact with people living with dementia. Could you offer suggestions on how we as an advocacy organization, Voices of Alzheimer's, might advocate for more effective personnel training to improve their individuals' ability to interact with people with dementia?
That's really a good point. Just as emergency medical providers, whether they're EMTs or emergency medical physicians, engage in training to deal with persons who have significant mental health issues, the same thing can be said of persons who are suffering with cognitive problems. You have to be able to recognize them. So I think that state to state, there are going to be differences depending upon how the medical systems are organized. But I think that from an advocacy point, and keep in mind, I'm a provider, I'm an educator, I need you to encourage your legislature to put more money into educating providers about not only Alzheimer's and related dementias, but any kind of geriatric medical problem. You know, older adults are going to be more of us, and I count myself in this group, and more providers need greater geriatric training. All providers need greater geriatric training. They need greater training in managing people with mental health problems. And it's not just the doctors. It is people who work in the community, firemen, policemen, EMTs. This whole network needs broader education around problems affecting older adults. Alzheimer's and related dementias are just one category of problems disproportionately affecting older adults. More education for providers on these kinds of issues, from the legislature to our medical schools.
Absolutely agree. So Terry, moving on to clinical trials, why do you think it's important for people with Alzheimer's to consider participating in a clinical trial?
I think it's all about education of putting the word out there and explaining that so people are not afraid of clinical trials, but to learn about it because a lot of times it's not offered. Now, more recent years, it is being offered. It's more publicity about clinical trials, and people are not stuck with saying, "Okay, I have a terminal illness." And you need to help the patients out a little bit more than to say you have a terminal illness. But you're not going, that terminal illness is not going to expire tomorrow. That means that you should go out, tell them about clinical trials, find information, go to different meetings of how you can be a participant in the clinical trial. If you qualify, find out what the qualifications are. And if you can't participate in that specific clinical trial, there's so many things that are out there to help us and to give us more knowledge in living with the disease.
Great, Terry. Thank you. Dr. Parker, what advice would you give someone interested in learning about trials and exploring potential participation in a trial?
There are websites nationally, clinicaltrials.gov, Research Match. That's one of my favorites. Research Match is you get on the national website and you put in information about the things that you're interested in, and you can pick a study. But all everybody's not eligible and a perfect candidate for all trials, as Mrs. Montgomery has stated. You may be interested in this, but you're not really a candidate for that particular study. I think that, again, there are national websites, but if you are near a teaching university, an academic institution, a medical school, a university, you can look at that university's website and find out what trials and clinical trial opportunities are available. Keep in mind, the studies aren't necessarily available in all institutions, but you can look at clinicaltrials.gov, which I think is difficult to manage, but you can also sign up for Research Match. If you're listening and looking for Alzheimer's trials, you can go to the Alzheimer's Association website and find out what clinical trials there are. But every university, and that's usually where most clinical research takes place, is going to have a listing of the clinical research studies that are there. I will tell you that people who have, for this particular purpose, who have been given a definitive diagnosis of Alzheimer's,
We're having we're having trouble with your audio, Dr. Parker.
Can you hear me now?
We can now.
Can you hear me?
Yes.
Okay. Check your university. The university clinical trials are available.
So also, there are many private research sites located around the nation, which service many individuals in Alzheimer's trials. So in addition, not only to the teaching universities that are available, often called ADRCs, there are private clinics that do a wonderful job of conducting national trials as well. So look for those in your area. And they're also, as Dr. Parker pointed out, available in these search tools that are online. The challenge, Dr. Parker, that I found is that it's very difficult to read the description of a trial and know which ones are the most appropriate for you. I usually encourage individuals to find the location that is nearest them or one that has a number of trials. Go in and let that location evaluate you and let them recommend to you what trials might be most appropriate for you to participate in.
Definitely. Because I'm a clinician, I'm kind of partial to being in a place where you can actually get medical care, and advice that's going to be comprehensive. So again, that's just the nature of the business of where I work. I want you to be
Certainly understand. We're continuing to have audio problems. So maybe we can take a break
Your
here.
doctor should be aware.
Agreed. Kim, I wondered if you, before we go on to the next questions, are there questions in the chat that you want to share with us?
Right, no questions as of yet. If anyone has a question, please feel free to put it in the chat, and then we can make sure that Terry, Jim, or Dr. Parker are able to answer. Thank you.
Okay. Come on, audience. You're going to let us off easy here, and I really want to put Dr. Parker and Terry on the spot. No questions for me, but we'll go. We've got a few more questions here. Dr. Parker and Terry, what do you see as the primary impediments? Why aren't, less than 1% of individuals with Alzheimer's in the United States participates in a clinical trial? Less than 1%. I mean, that's really a crisis, in my opinion. And we really need to double, triple, quadruple the percentage of people participating in trials. So why aren't people in clinical trials today with Alzheimer's? Terry?
Basically, in the past, we as African Americans was not told about clinical trials, but it's more pronounced now because there's more people being diagnosed with it. And then, like me, I was immediately interested in having it, but I did not qualify for it. But that didn't mean that I would end it at someone that I know or a circle of people that I know to spread that education and to ask their doctors about clinical trials. And like she mentioned, the resources that was there with the Alzheimer's Association during that time and so many places now. So you're seeing it on Facebook more. You're seeing it everywhere that you go and different advertisements. So that's a plus. To have that information out there and not be afraid that if you have another diagnosis, until they tell you no, then you see if you qualify, but at least find out about it and learn as much as you can. Spread the word, go to a meeting. The hospitals is always posting something.
Great. Dr. Parker, what do you think the major impediments are?
Lack of awareness, lack of availability. Those would be my two biggest ones. Lack of awareness, lack of access. Really, it's access. If your providers aren't aware, there's no access. If you're not aware, there's no access. So I think that creating a better place, just as we're talking about, a better place to find out about clinical trials is important, which is where advocacy groups come in. I think that advocacy groups can, on their websites, let people know of certain national trials that are going on that involve multiple centers. You talked about, research centers. That's an option, yes. But I think that advocacy groups, too, should bear some responsibility for making sure that their constituents are aware of what's available in their respective areas. That's something that advocacy groups can do. There's a trial on this medication. There's a treatment trial. There's a environmental trial going on. I mean, I'm in Metro Atlanta, so there are all kinds of research studies that are going on that may not have anything to do with medication, but all about caregiving, all about how to organize the environment so that people who are older and who have cognitive impairment can be more independent in their environment. And those are things that I think advocacy groups can look up. What's in this area? What's in that area that people may access?
So Dr. Parker is charging me and us at Voices of Alzheimer's to do a better job of keeping people aware of what their opportunities are. And one of the things that she just referred to is there are two types of trials. One's an interventional trial that treats the participant with medication. And then there are also observational trials. Many people apply to be in clinical trials and are not eligible and feel rejected. We don't do a very good job necessarily of channeling those folks into the opportunity to still participate in an observational or longitudinal trial. These trials are also making us much more knowledgeable about what it's like to live with Alzheimer's. And as Dr. Parker said, that there's really a great need for people in fact, when I refer to the less than 1%, those are the percentage of the people that are participating in observational trials. There are probably many more people who are participating in longitudinal trials, and we must really keep people informed of that as well. So we have a few 10 minutes here. Kim, please interrupt us if you have any questions from the viewers. So my last question to both of you is that a comment that we have come a long way, but clearly we have much more to do. 2023 was a hallmark year for people living with Alzheimer's. We know that PET scans for the first time, amyloid PET scans were covered by Medicare, so that diagnostics became easier. Continued reports that blood biomarkers are about to hit common practice. Disease-modifying therapies were approved, and we have the expectation of approval of an additional disease-modifying therapy soon. But what can the broader community do, Terry and Dr. Parker, to so that we remain active and vigilant in advocating for fair, equitable, and comprehensive treatment and coverage?
I think that in living with the disease, like for me, I'm a very strong advocate. And I believe in sharing information and getting those that have recently been diagnosed with the disease join and see if they will become advocates or if they will share the information to go to different meetings, to go to join as many organizations as you can, to participate as Dr. Price mentioned before in training institutions, how much awareness that they give. I mean, it's so much information out there. And the first thing is to get as many people we can that's living with the disease, either their parent or relative, become an advocate too, to learn more about the drugs that are there and more of the opportunities of clinical trials. So not be afraid of it, but come and find out. And we can't get to you if you don't come to us or listen to us. But we'll do our best through everything you see, all social media, any kind of way, the churches, there's no door that we do not try to knock on to bring awareness for Alzheimer's, for the treatment and the awareness.
I bet Dr. Parker can relate to a little bit of that not being listened to. Thoughts, Dr.
I
Parker?
can. But the other thing that I would strongly encourage for your listeners is the National Institutes of Aging, National Institutes of Health has a lot of materials available about learning about things. And one of the things that they have is information about clinical drug trials, any kind of treatment trial, caregiving trials that I'm trying to allude to. But making sure that as an advocacy group, you're aware of those opportunities. There are a lot of tools online. You're right. There's a lot of information out here, but we can't help people who don't know the resources and utilize them. As a clinical provider, I'm frequently encountering people who operate in crisis mode. They don't prevent things, they don't educate, they don't screen or prepare themselves for healthy aging. But when something goes awry, they want urgent, imminent treatment and they don't want to have to pay for it. And that's fine. But reality is that when you're an older adult, your primary insurance is Medicare. Okay? Medicare does not reimburse to the same levels that most private insurances do. So if there's any advocacy that I'd really strongly advocate in terms of policy, regardless of what state you live in, please try to make sure that Medicare dollars are better distributed, that providers that see persons over the age of 65 are compensated accordingly. I don't know why people think that doctors don't need to eat. Doctors do need to eat. Okay. Doctors have families too. And if I'm the provider taking care of geriatric patients, subspecialists may make 3 times as much as I'm going to get for one little visit, but Medicare needs to be Medicaid needs to be funded. Those are state policy issues. We won't be having enough providers to take care of the older population if we don't have providers, and providers aren't going to go into a career choice. I've spent the morning with a bunch of elementary school students if they can't pay their bills and take care of their families. Just saying, if you live in a state that doesn't fund Medicare or Medicaid appropriately, we're going to have a lot of people who don't get to see a doctor at all for any reason.
It's true.
Wow.
That's good.
This certainly has exceeded my expectations. Listeners, you have had 2 panelists who have challenged you directly in how we advocate and how we take care of our own health. And not only challenged you, but challenged voices of Alzheimer's. Now, we're supposed to be the grand providers here, but we're getting challenges in how we provide information to our members. And maybe just another reason, because we listen to Dr. Parker and to Terry, that you want to consider becoming a member of Voices of Alzheimer. Look at the great panelists we recruit. I just want to thank you, Dr. Parker and Terry Montgomery, so much for participating today. And obviously being in transit, Dr. Parker, from speaking to those school children to coming to work and conducting the webinar in transit is really wonderful of you. We really are proud of our Bill of Rights. We encourage all of you to go on our website and read it in fullness, not just the abbreviated, very abbreviated version that I gave you this morning. We hope that the conversation has been informative and empowering. We urge you to take action also by signing and sharing our Alzheimer's Bill of Rights, and join the growing list of more than 2,400 individuals who've already signed. So help champion fair and equitable treatment for those living with Alzheimer's. Before we conclude, I just want to make you aware that VOA is launching a podcast series titled Alzheimer's Voices, set to debut May 8th. This podcast will delve deep into the stories of insight and discussion surrounding Alzheimer's disease and related topics. We believe these podcasts will be a valuable resource for the community, providing a platform for further education, discussion, empowerment, and support. So stay tuned for more details about how you can tune in and engage with us. As mentioned earlier, this recording will be on our website and will be posted soon. At voicesofad.com if you'd like to share it or to listen to parts of it again. I think there are many sections of good advice, both from Terry and from Dr. Parker, that we could really learn from and perhaps worthy of re-listening. Also, you can sign up to be a VOA member at our website and support our organization and the many exciting programs that we have underway. So thank you for joining. Thank you again, to our wonderful speakers, Dr. Parker, Terry Montgomery, for your insights, your wisdom, and thank you for your dedication to people living with Alzheimer's. Have a great weekend, everyone. Goodbye.
Thank you.
Thank you.